Hello and welcome everyone. I'm Emma, the Volunteer Coordinator at Endometriosis UK, and tonight we'll be joined by Dr. Anne Connolly, who will be speaking on how to optimise your endometriosis primary care consultation during COVID-19.
My name's Anne Connolly and I am a GP. I'm based in Bradford. I work with, I spent all my years working in a large general practice in the centre of Bradford, and more recently, the last couple of years, I've been working with the asylum seekers and refugees and the homeless and the sex workers. So very challenging but very interesting career. I have a passion for women's health, and I've been working closely with Endometriosis UK for the last few years, developing some work for the Royal College of GPs to try and raise awareness about women's health issues, specifically bleeding problems and specifically endometriosis. There is no such thing as the daft question. I'm sure you've got lots of things that you might want to know from a GP. What I'm going to do is I'm going to talk through a little bit about the challenge for us in primary care about being a GP and about particularly endometriosis. I'm going to talk a little bit about what it's like at the moment, because it is I've worked in general practice for a lot of years, and I've never ever known it like it is at the moment. So I'll talk to you a little bit about the challenges we've got. I've got a few thoughts about how we can work better and how I can empower women to come to us with bleeding problems, and maybe words and things to use. And then, as Emma said, we've got some questions. So I attended the all-party parliamentary group report this time. I also attended 3 years ago, and that's when the work for the RCGP started after the first report. When it was identified, it took such a long time for women with endometriosis to get a diagnosis. It's very disappointing to see that we haven't particularly made a difference to that. We can talk about what a diagnosis means for endometriosis, because it's a challenge, and we can talk about how women perceive when they get the diagnosis, because obviously it's laparoscopy that makes that diagnosis, or improvement with medicines might also make that diagnosis, but again, that's a challenge. But shockingly, we've seen this report talking about how many times women come to us as GPs, and even the hospital doctors before they feel they get the diagnosis they need. We've seen a lot of women attending A&E with painful periods, painful bleeding, and other symptoms caused by endometriosis. And again, that's not ideal. So this has given us another challenge. You'll have read the report. You'll have seen what the Endometriosis UK plan to what the ambitions are from this report, and they are fine ambitions. I have to congratulate Endometriosis UK all the time for the work they're doing on behalf of women. And they've really got some good high-powered MPs involved now, who will be asking the right questions and who are promising to do the right things. So once the COVID pressures settle down and we get past the latest Brexit business, perhaps we will start to see some women's health work happening. There are certainly all the right people around the table. You'll know this because I guess a lot of people who are on this call are endometriosis are sufferers or carers of. It is known as the missed disease. You'll know it's the tissue that normally ought to be inside the womb in places where it shouldn't be. And every month we go through hormonal changes. The lining of the womb, the endometrium, gets thicker, and then we get another change in non-pregnant women, and that endometrium dies, and then it sheds as a period. If it's inside the womb, it comes out as a period. If you've got that endometriosis somewhere else, when it bleeds, it causes pain, it causes scarring, it causes inflammation, and that goes on to cause the secondary problems, which are scarring, adhesions, infertility, subfertility, chronic pelvic pain. So you'll know that. And again, Endometriosis UK have got such fantastic information about that that's really, really helpful for us as clinicians to understand, and also for women and their carers to understand. It's common, and this is a challenge for us again, and we'll talk about who gets referred and who doesn't, who has laparoscopy and who doesn't. But anywhere between 1 in 20, 1 in 10 women will have endometriosis, which is a phenomenal amount of work for gynecologists to need to deal with. And we know that some women get very few symptoms, but on laparoscopy they'll have lots of endometriosis, and some women get lots of symptoms, but at laparoscopy they will get very few findings. So it's a very complex disease, and one of the big request from the All Party Parliamentary Group is that so much more research is needed. As I say, the difficulty, I as a GP, I will hear a woman's story because I have a passion for women's health. I hope I pick that up a little bit more quickly than maybe another GP, and there is the pattern to the presentation if you understand it. And I could perhaps say to a woman who comes with a cyclical painful bleed or other symptoms, I think you've got endometriosis, and then we could use hormone treatment if that was her choice. But is that the diagnosis? Is that the time I've made the diagnosis? Because for me, I would hope that would be fairly early on. But other people feel that diagnosis is only made when you've had your laparoscopy. Well, that if every woman, and we're talking about up to 10% of the population, do that number of women need to go through a procedure that does have risk to make the diagnosis? And that's a big question. We know that treatments aren't always that great, and some women will go through surgery and surgery and surgery again, and each time the surgery happens, the outcomes are less good because it gets more complex surgery. And we know that the ambition is to stop not just the acute symptoms, but also the longer term complications that we've talked about scarring and about subfertility and pain. So that's endometriosis, and I'm sure lots of you know far more about endometriosis than that, and possibly than I do. Now, a few years ago, we had the NICE guideline. You'll know that as GPs, we have to try and work to NICE guidelines. The problem is NICE guidelines come out of the woodwork. We will have endless NICE guidelines being thrown at us. So it's really hard to keep up with everyone all of the time. But the quality standards are a great way of us auditing our care. So every so often as GPs, every year we have to have an appraisal. They're on hold at the moment, but every year I have to present evidence of learning and evidence of reflection and evidence that I'm performing right. And every 5 years I have to have a reaccreditation, and I have to demonstrate audits and patient satisfaction, etc. And this makes a good audit, the quality statements. So endometriosis does, heavy menstrual bleeding does, menopause management, there's one. And there are just 3 statements in this, and two are more relevant for me in primary care. But if you read those, you'll say, well, statement 1, we should do an abdominal and possibly a pelvic examination. Well, that's not necessary at the moment, I have to say. We're doing a lot more over telephone, which is okay, but not always okay. And some of you will have been frustrated that you haven't been to see a GP yet, and whereas we at general practice are trying to protect our staff, protect our patients from coming into a high risk environment. So we could say that that's best practice. Often when we examine women with endometriosis, there are no clinical findings in primary care, and what I'm doing is excluding other things, really. And then statement 2, I will have a debate a lot with the endometriosis team about whether we refer women straight into a gynae service or whether we try hormone management first. And actually statement 2 there suggests we should try hormone treatment first. And then if not effective, not tolerated, or actually it should say if patient requests, referring to the hospital service. Statement 3 is clever stuff. That's for clever people who live in hospitals. So you can see that's sort of the standard that we're meant to be working to, but it's very hard. I live and breathe this stuff. I know this one, but if you talk to me about diabetes, I wouldn't know what the quality standards would say, just because there are hundreds and hundreds of NICE guidelines. So for us in primary care, this is a little bit of a please apologise to us, or I'm apologising on behalf, but trying to justify what's going on. I can see in my clinic, I will have a child with a rash. I will have an older person who's having falls. My next patient will be, particularly at the moment, something around mental health. My next patient will be someone ringing up with COVID type symptoms. I'll have somebody else with pain in their knee. So you can imagine, we've got to know something about everything. We don't have to be experts in everything, and we can't be. What we need to know is enough about everything to know when to manage, when to refer, when to signpost, when to investigate. That's sort of what we have to do, and we have to have our boundaries. Some of us will know a lot more about diabetes, some will know a lot more about respiratory disease, and you're lucky if you get the right person first time. Workload, over the years, workload has gone up and up and up and up, and at the moment it's fairly unbelievable. We have shifted onto telephone triage, which I think has some benefits, and I'm sure telephone triage will stay. I think we will manage it differently. We will end up seeing more women, more patients in the clinic as the COVID risk reduces. But I think if you've done a telephone triage appointment, if you've had one, you might find it much easier than having to take time off to come to the clinic, to wait, because we're always running late because we're GPs. And the same with the hospitals. Lots more will be done more conveniently over the phone. And we will learn that skill better. It's been a rapid learning curve for us to deliver care over the phone as well as for patients to understand what it's about. Appointment lengths, you'll know that we have 10-minute appointment lengths, which is never enough. It's never enough to do all the stuff the information we have to collect as part of our work, such as smoking status, or medication reviews, doing a chronic disease management assessment, mental health, as well as then dealing with the problem. And if you, God forbid, you come with a few problems, that makes it really, really complex. I'm sure, again, you've hit that as a barrier at times. In primary care, we have priorities. We have to do our emergency work. We have to do our chronic disease work. We have big, and funding is different. We are small businesses, so we get funded, we get payments for different things, and that sometimes directs the priorities. So a lot of pressure on us to get chronic disease management, and unfortunately endometriosis does not classify as one of our chronic diseases. And again, we could discuss I'll agree with you, that's wrong. The chronic diseases are respiratory disease, mental health, cardiovascular disease, diabetes. They're the main ones, and money follows that. So we are pushed to prioritize those. And at the moment, our big priority is getting through COVID. Keeping up to date, I've tried to talk a little bit about challenges with that, but I have to demonstrate at my appraisal that I have done a little bit of treat about palliative care. I've done a little bit about chronic disease management, and I've done a bit about everything to keep me there as a generalist. And then I have to do extra as a GP with special interest in women's health. I have to demonstrate extra learning for that. The learning new skills, I just put these down as a list, and they seem a bit uncoordinated, but the learning new skills is really about us telephone triage, and then having to wear masks and visors and everything as we try and communicate with our patients. I have to say, it's a big challenge for me trying to do things with using interpreters over the phone with a mask, and trying to understand what the patient's saying through a mask. Lots of our population, and certainly much more than when I started 30 years ago in general practice, our population is aging. We are actually becoming more unhealthy. So lots of people have comorbidities and complexity. So, dealing with or doing a home visit on a frail elderly person who has social needs, falling, not eating well, mental health issues, that sort of complexity is very difficult and increasing. Gone are the days when we would just bounce around saying hello to a nice postnatal mum and looking at the baby and taking that as a visit, whereas someone else had to go and do the complex elderly. And the other thing that we are pushed at is about referral pathways. So to try and streamline everybody's practice so that it keeps us easier up to date and understanding what the latest NICE guidance is on our computer systems, we will have referral pathways, and they are very localized. So you take NICE guidance, you put it into a local pathway. And so some people will hit a barrier because we have to follow that local referral pathway. And if we refer into the hospital at the wrong time, then we get bounced back sometimes and we have to do another step before we can refer back in. So they're sort of barriers that I think are there. And I'm trying to explain what it's like as a GP, because it's not straightforward. So working together, I was trying to think of a few things that I think are helpful when somebody comes to see me. A menstrual diary is a godsend. You can, we're taking things. I don't know if anybody's tried doing a phone consultation where we've then done a video call, or you've managed to text something in or send something in on a e-consult. But a menstrual diary is often very helpful for us. If you're trying to explain about the cyclical nature of some of the symptoms, it's very good for menopause, it's good for heavy bleeding, for erratic bleeding, for painful bleeding, for PMS, for mood problems. And again, Endometriosis UK have a great one on their website that you can download, but lots of people have them on phones these days as apps. That's really helpful. Some people don't like them, but I think that I think sometimes people are frightened when people, as GPs, when people come in with a load of information. But actually, a menstrual diary is very straightforward, because often we'll then say, well, go away and keep a menstrual diary. Whereas if that's an upfront thing, then it's helpful. So what about how to communicate? Certainly, write down your concerns, because I know when I go and see my GP, I'll often be flabbergasted by being in the room or on the phone. And sometimes I think, oh, why didn't I say that? Or actually that bit mattered more to me than that bit did. So we get into a situation where we feel out of control, nervous. You've finally got to talk to the person you think's going to give you barriers or whatever. But write it down in an ordered fashion and say it as it is. As GPs, or certainly, I like to know what it means to you, how it affects you. Not about whether people think they've got this and they want this management, but it's about what this problem matters to you, how it affects you in your daily life. Because if you are having to take 3 days off work every month, or avoid or not go to school, or missing your exams, or under pressure at work, or social life, or sex life, or whatever, that's the fact that that this problem has that impact on your life makes me understand it better. If you say I have painful periods, I'll probably say to you, so out of 0 to 10, what's, 0 being okay and 10 being the worst, where are you? And you might say 8 or whatever. But actually, if you say to me, this has so much impact on me that I cannot, and it affects me like this, that's the most important bit. And NICE tell us that as well. But be honest, be clear, try and be as ordered in your mind's thoughts as you can, so that we have a conversation that is right for you and also makes it easier for me as a clinician. If I use fancy words, then say to me, please stop using fancy words. Please say it as it is. I've worked in the centre of Bradford with such a diverse population. I've had to learn to communicate in different ways culturally. Using an interpreter is really hard if you're trying to explain a problem like endometriosis. But if you don't understand what's being said, then ask the GP to say it again, and so that you don't come off the phone thinking, what on earth did they say? And write it down. If there's follow-up questions, or you want to say, okay, I'll try this, if that's what you're recommending, then when can I be reviewed? Let's agree now. You say that to us. When is it you're going to review me? because NICE tell us we should review. We often don't. We say, oh, come back if it hasn't settled or whatever. But say shall I make an appointment in 4 weeks? Shall I make an appointment in 2 months? Just make sure that you are okay with where the follow-up is. Dr. Google is probably the most dangerous and the most frustrating thing for us as doctors, because people write stuff on the internet when they're angry, when they're upset, when they haven't had help. Much more likely to write on the internet, that doctor did this, or this treatment was awful, or whatever. Whereas if you've got a good treatment, or you've got a caring doctor, or you've found this really helpful, you're much less likely to write it on Facebook or whatever your social media is, but also as a resource on internet. So some Dr. Google gets to be quite difficult for us, because we're there, we're trying to deal with the problem, and then we're having to undo the myths, and then we're having to sometimes people will come clutching, oh, this research paper has been published and this treatment is being used in some other country, and we have to it's working from a different level. You have to start the conversation again, but getting through the myths is quite complex. So Endo UK is fantastic as a resource, and there are lots of other reliable resources, and patient.info is getting better and better. But please think about the resources that you're using. I'm not happy with bleeding problem resources. I say that all the time, because you have to have a diagnosis before you then go and look at the website, or at least somebody's had to say, I think you might have endometriosis. So it's not, you can't, Googling painful periods isn't, or heavy periods, you don't get lots of good resources straight up. If you're not happy with one doctor, if you come and see me and I don't give you the answer, or you don't feel that I've listened properly, or I've cared properly, or I've been dismissive or whatever, then everyone's entitled to go to another doctor. The practice websites will have on all your GPs and nurse practitioners, and they will have them listed, and they will say this doctor's got these qualifications and this is their interest. So if you've not seen the women's health doctor, but you've seen the diabetic specialist, and you want a women's health issue, then go back and say, I'd like to see that doctor next time. You are entitled to a referral. Everybody, we do like, as GPs, especially if we've got a performer that we've got to go down, especially if we've got a referral template we've got to go down, we do like to try and follow that. But if you're not getting the response, or everybody's entitled to see somebody. At the moment, referrals are being very delayed, so don't be surprised if it's a long time if you are referred, but you are all entitled to that. And at the end of the day, if you don't get what you're wanting from a GP practice, then register elsewhere. You do not have to go and explain to the GP why you're leaving and why you're registering somewhere else. You can just change. So feel free to change if you are not happy. And they were just some thoughts I had about how we can improve the consultation. This is some work I'm doing with Endo UK. You can see the logo on there for the RCGP. As I said at the beginning, this was set up following the first all-party parliamentary group of three years ago, and we've been trying to work together to develop this toolkit. It's a one-step resource for GPs in surgery, just to be able to go click and find all the resources that are there. And we're expanding it, and we're doing a COVID section at the moment. So that's there. Anybody can have a look and see the work we've been doing. So that's what I thought I'd say. And these are the questions that Emma gave me beforehand. Obviously, I know there's some more that have come through. What you have to know is that I am not, although I work at the hospital, I hysteroscope, so I'm not an endometriosis expert in the hospital. So I'm trying to avoid any of the really tricky surgery questions, because that isn't my area of expertise. What should I do if I have endometriosis symptoms? My GP says I do not have endometriosis. So lots of you on this call will be expert patients. You will know more than your GP does. about endometriosis. If you have symptoms, then for me, it's about, particularly in the early days, about watching that cyclical change. That's what will make me think about endometriosis, and that's what will make a GP think about endometriosis. By the time you are 8 years down the line, then you may well have more chronic symptoms, the pain being all month, which then makes it a little bit more complex and harder for us to untangle. So if you have endometriosis symptoms that have been progressed because you've put up with them for a long time, we know women put up with their symptoms for a long time because they don't think they can go and talk to us. Then go back to the beginning and think, when I started, when I was 14, what I will often say to women will say, so when did your symptoms start? What were your periods like to start with? So give that information. You can say, I started my periods when I was 14. When I was 16, I was off school with my periods because they were so painful. I'm now 25 and I'm still, but it's become more chronic. That would make a GP think about that. Again, we've talked about you can go to a different GP, you can go to a different practice. So don't just put up with what you're told first time. And do your research, go back again, read Endometriosis UK and then go back to the GP with your menstrual diary. Be empowered. As I say, we don't know everything about everything all of the time. We just have to do what we can. If your medication isn't working, NICE clearly put out what we should do, and the treatments to start with are hormonal or non-hormonal, so painkillers or hormones to try and stop the bleeding, stop you ovulating, and that is a choice that you'll be given. You can take a combination of those. But if you get to where the medication and you've had an appropriate medication and it's not working, then again, go back to your GP and say, this isn't doing for me. Maybe you want a referral. But as I say, at the moment, it's quite complex about referrals because lots of hospitals aren't taking them. Surgery delays and prioritising of vulnerable patients. The BSG centres still taking on new patients. That's very, every hospital is trying to do what it can at the moment. Some hospitals will be taking patients, some won't. I suspect lots of the hospitals down in the southeast and London are not taking what we call routine referrals at the moment. And endometriosis, unless it's an acute episode, would be deemed to be a routine referral. Up here in Bradford, we had a time a little while ago where we couldn't refer to the hospital, but that has now resolved, and at the moment we can still refer in, and the waiting list is just building up and up and up. As GPs, we should be supporting you in the interim, with the treatments that we know are on the hormone or the painkillers, and giving as much support as we can. That's our job. We provide sick notes. We can write a letter to your employer to say, while we're waiting for 3 days, 5 days before the period, you can't, be more flexible about working. I can write that as a letter that people could use. Reluctant to provide information. How can we get more answers and support from them effectively? There's a lot of stuff online. It is worth trying to look at the good resources and then go to the GP with the information. Say, I've read this, and do you think this fits my symptoms? If you've hit a number of GPs who aren't really supporting you, I'm sure there's a lot of frustration there, a lot of anger there. Trying to be as calm as possible, again, writing it down in an ordered fashion so that in some ways that makes the consultation easier on both sides. Especially when we're not doing things face to face, it's a different skill over the telephone. And in some ways, it's easier to shut the consultation down over the phone than it is when somebody's in the room. We miss a lot of the visual cues. So if you are really upset, we will, or trying not to be too frustrated, then it is harder to do that over the phone. And often I would say to people, in the good old days when we were seeing patients more readily, bring someone with you, where at the moment we're saying don't bring someone with you, again because of the trying to keep people out of the building because of protecting people from COVID. If you're worried about your fertility, so we know that endometriosis is a cause of subfertility or even infertility, because all that bleeding, if it's happening after, and all that inflammation will cause or can cause tubal scarring, and then if the tubes then become closed, then the egg and the sperm can't meet. So that is an ongoing problem, but and if you have endometriosis, you qualify for referral into the fertility unit quicker than somebody who has no pathology or no known pathology. So NICE fertility guidance will talk about women having to wait for 12 months before being referred into a fertility unit. And again, local areas will have modified that. But if you have endometriosis or polycystic ovary syndrome or another gynae condition that we know reduces fertility, you don't have to wait that 12 months before being referred in to the fertility unit. And if you want to, go to your GP with that, then look at the NICE fertility guidance, and it's there as one of the recommendations. But you can't have, there aren't tests to see if you can conceive. And you also have to remember that a third of the issues with fertility issues are due to male factor. So fertility, if you've got tubal damage or some tubal scarring, it doesn't mean that that is necessarily the cause, the total cause for the subfertility, because actually there may still be enough passage of sperm and egg for you to be okay. But it may be the male problem, and lots of times there's no cause found. So you can't, if you have endometriosis, go to your GP to ask to be referred to a fertility unit for tubal patency if you're not trying to conceive. Unfortunately, that's not an option on the NHS anyway. Operation waiting list for a long time, and they will be long at the moment. Talk clinical support. I think I know some of the units are triaging over the phone, and they are recommending Prostap injections, which are the GnRH analogues, which are the way of making women behave menopausally. And that's sort of once we go through the menopause, we know our symptoms the pain will reduce because you're not having that regular bleeding. So that I know is one of the things that are being recommended at the moment. The trouble is you can't use those for a long time because they have side effects, and they make you menopausal basically. So not only do you have the flushes and the sweats, but you also have bone health risk, osteoporosis risk. So they are used usually in short term before surgery, but I know more are being used at the moment. The next question, is it common for abnormal uterine bleeding lasting 7 weeks to be caused by endometriosis post-menopause? Well, postmenopausal bleeding. So postmenopausal bleeding is bleeding more than 1 year after your last period if you're not using hormones. So that means you're not on HRT, you're not using contraception. And postmenopausal bleeding is endometrial cancer, so it's womb cancer until proven otherwise. So anyone who bleeds more than 1 year after their last periods needs referral by what we call a fast track. So that's an emergency. It's a cancer referral into the hospital, and you should be seen within 2 weeks. With postmenopausal bleeding, you go, because that's the clinic I'll be doing tomorrow morning, is the postmenopausal bleeding clinic at the hospital, and the women come in, they have an ultrasound scan. If the scan shows certain findings, then we reassure them and send them home. But if the scan shows other findings, then I put a telescope into the womb to check the lining of the womb. So it's a difficult question, this, because if we know that womb cancer has definitely been ruled out because somebody has done a hysteroscopy, it won't be the endometriosis that's causing the bleeding, but it will be something else, such as atrophy, so dryness, postmenopausal dryness, or we'd have to check that there wasn't an ovarian problem causing it, or a problem from bleeding from the cervix. But it's that's not an easy question to answer, that one. And it certainly isn't caused by endometriosis, no. Endometriosis is painful bleeding. It is not, and scarring. It is not erratic bleeding. I think I've answered the last one, and I don't know which areas it is. My guess is where the hospitals are under real pressure. The problem for surgery, particularly bigger surgery, is no one will embark on surgery where you may need a ITU bed, an intensive care bed, when there aren't any intensive care beds. So if it is complex surgery, such as, big surgery, hysterectomy, removing the ovaries, endless scarring, and or even more complex than that, and there is a risk that you would need to go on to intensive care, and there is not an intensive care bed because they're full of COVID patients, that surgery cannot be done because of the risk of then you being stuck with no intensive care facility. So lots of surgery is being delayed at the moment. The staff are being moved on to cover the COVID response. On the whole, gynae staff are being protected more than some because they are having to cover obstetrics. But some staff members are off. They're either being isolated because they've got COVID, or they're living with people with COVID. So generally, healthcare professionals are down anyway. But you then also, for surgery, you may not have the theatre staff to assist, you may not have the porters to assist, you may not have the beds in case people have to stay overnight. So there are real reasons, very logical reasons, that surgery is being delayed at the moment. So that was the questions I had so far. I feel a bit like this cat right now walking in front of all these dogs, because I guess there's going to be some frustration with GPs. I will stand up and know that say to you now, if you had a respiratory problem or a diabetic problem, I am not the person to come to talk to. But if you have a gynae problem, I hope I am. And that's how it is for everybody in general practice. So I hope that was a bit of an overview that was useful, Emma.
Yes, thank you, Anne. Thank you so much. I've got a few more questions, if that's
Great.
okay with you. So the first one is bleeding after sex a common symptom of endometriosis?
Right. So the answer is no. Bleeding after sex is usually a problem. If you remember that picture, and I don't know if everybody knows about the female anatomy, but we've got the ovaries, and then we've got the tubes, and then we've got the womb, and then we've got the cervix, and then you've got the vagina and the vulva. Now, bleeding after sex is usually a problem from the vulva, the vagina, or the cervix. So it's a problem at the bottom part of the gynae tract. Bleeding between periods or heavy periods is usually a problem above that, and postmenopausal bleeding is usually a problem above that. So post-coital bleeding, so bleeding after sex, you need to be examined. You need to make sure your smear is up to date. You need to make sure that you don't have a sexually transmitted infection, because that can cause post-coital bleeding. You need to make sure lots of women will have post-coital bleeding postmenopausally because of the dryness. Some women will get post-coital bleeding because of or bleeding after sex is post-coital bleeding because of problems with, if they've got eczema or problems with the skin. But normally, unless you've got patches of endometriosis in the vagina or on the cervix, which is rare, then you wouldn't expect it to be down to endometriosis. So if you've got post-coital bleeding, please talk to your GP. Don't put it off.
Thanks, Anne. And the next one is, sorry, I always stumble on this word, endometriosis.
Adenomyosis.
Yes, thanks. Be seen during a laparoscopy.
So adenomyosis is, for me, in my little simple brain, adenomyosis is endometriosis in the muscle of the womb. So the womb is about a fist size. Most of it is muscle. And most of it is muscle because it has to grow from this to a pregnancy size and back down again. So adenomyosis is endometriosis inside that muscle. And every month it goes through the same changes. So it bleeds, so you get painful periods, but it's happening inside the muscle. So if you're doing a laparoscopy, that is going to look around the womb. It looks at the ovaries, it looks outside the tubes, it looks at the bowel, but it doesn't look inside the muscle. So adenomyosis may not be seen on a laparoscopy or a hysteroscopy, because as a hysteroscopy, with hysteroscopy, the telescope test, I'm just going to go inside the womb and look at the lining of the womb. So again, I'm not going to be looking in the muscle.
Right, thank you. And can endometriosis cause a continuously increased temperature?
That's a good question. I have never seen it. I've never read it. I guess the answer is no. I'm sure someone will find some fabulous research paper somewhere that says it could do, because it's an inflammatory response, but not routinely.
Right. And why do you think that endometriosis doesn't count for a chronic disease?
It's a good question. It's a seriously good question. Because it affects women. And you know, it's something that we've been poor at complaining about. You know, Endo UK, I've just seen a study today and I wish I'd remembered the figures, but I'm sure it will be on your website very soon. But there's a new survey. I don't know if you've seen it, Emma. There's a new survey that talks about the number of women who don't complain to their GP, who don't complain to their employer. I've just seen the results of it today, so I don't know if it's been launched yet, but it's going to, I'm sure you'll put it on your website.
But, yeah, it hasn't been shared just yet.
Oh, okay. So I better not share it. Well, I can't remember the figures either. But, you know, it's phenomenal. The number of women who put up with heavy periods and painful periods, even if you're, you know, you're having to miss time off work or change your job because of the problem. We just tolerate it. So it's been underreported. That's one point. The other one is that, you know, we're very, we do a lot of work around diabetes and cardiovascular disease, and those problems are increasing, but they're associated with mortality as well as morbidity, whereas endometriosis is morbidity as opposed to mortality. So I guess that's the other one. But there really is, it's the bottom line is it's because it doesn't affect men.
Okay, some practices seem reluctant to promote local support groups. What would you suggest to support group volunteers to get their promotional materials into surgeries?
Good question. I would, you have to remember how many conditions there are. So, you know, and we're not allowed to put posters up like we used to. And we're not, particularly at the moment, we're not having paper lying around in the surgery. So it's hard to know how best to do that. It might be worth talking to the CCG, to their comms department. So every CCG has a communications team, and they would be able to signpost you to the they might be able to share information through we get weekly, at the moment we're getting daily communications from our comms teams. It might be worth talking to the other local support groups so that you can share information, particularly women's groups. But really, at the end of the day, it's just keep going, really.
Okay. So is there a connection between moods and anxiety around times of period?
Is there a connection between mood and anxiety?
Yeah, around times of period.
Definitely. There's something called, well, they call it PMS, premenstrual syndrome, and then the more significant problem against PMDD, premenopausal dysphoric disorder. And again, that's where a menstrual diary works really well, because if you think, oh, my mood changes throughout the month, but you can really, if you document it and you can see the pattern of it, then it becomes easier to then think about how we can support you. Because if your mood is, if you've got low mood or anxiety and it's there all the month, then we might use this type of management or recommend that type of support. But if we know it's hormonally related, then we can suggest hormones or other self-help methods. So there's a good PMS society, so the PMS, premenstrual syndrome society, have some good information on.
Okay. So does hormone treatment treat endometriosis or just act as pain relief?
So what hormone treatment, so if the reason for the problems with endometriosis is because of bleeding. Bleeding causes pain and bleeding causes scarring. So the ambition is to stop you bleeding. If we can stop ovulation and stop bleeding, we will stop the majority of the problem at the time and also the ongoing consequences of scarring. So that's sort of basically the ambition. It doesn't work for everybody, and we know it's more complex than that, and we know some women, even when they are made to stop bleeding, they will still have problems in the early phases. So it's a very complex problem. But what the ambition of stopping bleeding does is to stop the pain, make life more bearable, but also to try and stop some of the longer term consequences. So it doesn't reverse the endometriosis, it doesn't cure it, but it tries to reduce the amount of problems.
Thank you, Anne. The next one is, if an ultrasound auditory shows an endometrioma, what should the next steps be?
Okay, so an endometrioma is in the ovary, and basically it's a little cyst, and it will have some endometriosis inside it. And every month, because of the hormone changes, that endometriosis inside that cyst will bleed. So it causes the cyst to get bigger, and they're often called chocolate cysts because the blood that's inside it loses its redness and becomes a brown color, and that's a chocolate cyst. And when they look at it under the scan, an ultrasound scan, they will say that it's a cyst that, and they will notice that there's a pattern inside that cyst which looks like a fluid, and it'll be not just a clear fluid but a more solid fluid, because that's, the blood starts to clot, and they will tell you it's an endometrioma. Now, if it's just a very small one, then they might choose not to do anything about it. So it's about the size of it that causes the problems, because if you've got a large endometrioma, that is quite a heavy thing inside the ovary, and the risk is that it might burst or it might twist. And if it twists, then it can cause acute pain. So endometriomas depend on the size, depend on the number, but they often have to have surgery to remove them.
Thank you, Anne. So what are the risks of having a laparoscopy, and how high is the risk of complications?
Okay. So a laparoscopy is where I'm sure lots of people who are listening have had a laparoscopy, and you had to sign the consent form to say blah blah blah, that, you know, the risk of this, the risk of that, the risk of the other. The first thing with a laparoscopy is you have to have a general anaesthetic. You always have to sign that there is a risk to a general anaesthetic, and on the consent form there will always be the word death. So you have to sign that. It might be 1 in a million, but you have to sign that that is a risk that you take. Because as soon as you have a general anaesthetic, you have to sign up to Anesthetic Risks. With the laparoscope, they put it through, make a little cut by the umbilicus and a little cut down in one side, above in you know, the lower part of your abdomen. And they'll put the telescope through one and a pair of forceps or whatever burning machine it is that goes through the other. Now, those are put in blind. So one is put in through a cut, and then some gas is put in, and then that tries to expand the cavity. So the other one, when it's put in, doesn't hit anything. But there's always a risk that you'll hit I don't do laparoscopies. There's always a risk that surgeon might hit bowel, or they might hit a blood vessel, and when you sign that form for your consent, you have to sign that if they hit something that they shouldn't have hit, you will end up with a full-blown scar, because they might have to cut to find the bit that's caused the bleeding or whatever it is. The other risks then with the diathermy is that often little patches of endometriosis are hidden, and they're hidden on the bowel, and they have to burn onto the bowel, or they might be hit by around the blood vessels, and they have to burn on those. So it's really complex surgery, and it should be done by someone who really knows what they're doing. The other risks you have are about your own health. So if you are overweight or if you are underweight, then the risks of laparoscopy are higher. If you have had a long history of endometriosis, or you've had multiple bits of surgery, then there may be scarring. And so the bits that they want to move out of the way when they put the laparoscope in might not move out of the way like you'd think they would do because of the scarring. So again, there's higher risks. So everyone who goes for a laparoscopy needs to be counseled about what the individual risks are for them. And they will depend on number of amounts of surgery, time of endometriosis, weight, and then anesthetic risks such as asthma, epilepsy, other problems. So it's not a straightforward answer, I'm afraid.
Okay, our next one. So someone has, I think you've answered this already, but it's come in just now, so they might have missed it. So they've been prescribed medication, and that they still have pain.
Okay.
And they were wondering, well, what next should they do if they've been prescribed that by their GP?
Okay, so I mean, it really depends what the medication is. If it's a if it's a codeine, or it's a ibuprofen, or something basic, then go back and ask for something a little bit stronger. We have a pain ladder that we work up. The problem with the pain ladders is that the people then start to get addicted to some of the medicines we use, and then it's hard to get to reduce the amount of painkillers that we're using. So there's a real push at the moment about how we use painkillers, because they have been abused over the years. There are other ways of helping with pain. Sometimes it's around we use a pain specialist at time to help us with pain management skills, distraction therapies, TNS machines. There are other ways of looking at about pain. Depends how bad that pain is. Sometimes it's worth using hormones as well as painkillers as a combination. But if you're really at the wit's end, then it's about asking, because we have other ways of contacting our gynecologists. So the gynecologist in Bradford might say, oh, we're not taking referrals at the moment because the hospital is so full. But as a GP, I can ring up and go, I've got Emma, she's there, and she's got this problem, and I've tried this, that, and the other. what would you recommend I do now? And so they might, we sometimes send email requests in, so there are other ways of getting expert opinion without actually seeing the expert. So go back to the GP, go back and say it's not working.
Excellent. So is it ever the case that a laparoscopy won't reveal endometriosis even if you have all the symptoms?
Absolutely. It's a really bizarre problem. And we don't have so many women going for sterilization these days because of the other contraceptive methods and vasectomy being better. But there was a paper written that showed that there were a lot of women who were having sterilization who had significant endometriosis, but no symptoms. And there are also women who have surgery for their endometriosis where the gynecologist will look and find very little. So it's about the inflammatory response rather than actually the number of patches in some.
Okay. And will you still receive a diagnosis even if it doesn't show?
Well, that's the specialist to tell you that one. I'm sure they would find a patch somewhere and give you the diagnosis. So I'll leave that to the clever specialist to answer that one.
Thanks, Anne. So with current delays getting seen around COVID, how damaging are the risks of waiting without being seen and endo developing further?
Well, it's a risk. Yeah, I mean, it's a risk, but we're having to make some very difficult decisions at the moment. You'll see it in the press all the time. There's we're at a stage now where we've been told in some areas that even cervical screening has to be stopped. We've never been in this position. We never imagined we'd be in this position. So people are doing the best they can in the circumstances. But as I say, I've never seen anything like it, and I don't want to live through this ever again. What I would suggest is, if you are somebody who has been, there are a lot of anti-hormone people. So if you are someone who said, I don't want to try hormones, or I've tried them before and they didn't work enough, I would suggest that you might reconsider the use of hormones, because it would reduce some of the consequences as well. So please consider revisiting that, because it is something that we as GPs can be doing.
So next question, are the risks of scar tissue from surgery better than the risks of an endometrioma and endometriosis?
So an endometrioma needs to be taken out because of the risks of it twisting and then getting an acute problem, and then you end up with acute surgery done by somebody who may not be the expert. So endometriomas are a different issue. Endometriosis and scar tissue, that really is, that's the sort of question that you need to ask the surgeon who is going to be doing the surgery, because they will be counseling and they will have more of an idea of what they're anticipating on finding when they do the surgery. So generally, I don't believe everyone with endometriosis should have a laparoscopy. I don't, because I don't think everybody needs a laparoscopy. And I think the risks generally are higher, but lots of women will need laparoscopy to get rid of the endometriosis, and there's good with diathermy, and there's good outcomes with that. But the better the skill the surgeon, the better the outcomes.
I think I have a fairly easier question for you. So should a young female patient mention that they have painful periods that have lasted for 3 months at a time, could this be a symptom of endometriosis?
So the period shouldn't last for long. Endometriosis shouldn't cause an altered pattern in bleeding. Endometriosis should cause pain to start with, particularly a younger woman, pain around, you usually know it's coming. So you get pain starting before the period and then last during the period, and then it should reduce. The chronic problem of it is the scarring, which goes on later. But endometriosis should not cause prolonged bleeding. Prolonged bleeding might be due to pelvic infection, endometrial pathology, hormone use, but it shouldn't be the endometriosis that caused 3 months prolonged bleeding.
Do you, in particular, suggest referral counselling services?
Referral to counselling services?
Yeah.
For endometriosis?
Yes.
I certainly use a lot of counselling services and a lot of support services, and increasingly with the way the NHS plan will have us moving in the future once the COVID response is done, we will be developing in primary care networks, and that will be much more supported by voluntary sector, by mental health services, trying to reduce the need for everybody to see a doctor or a specialist all the time, but optimizing the skills of the multidisciplinary team and the support networks. I passionately believe that we support each other better. I don't believe that me as a doctor knows all the answers, and I have watched over the years the lack of local support, maybe not with COVID, but say if we were having this conversation a year ago, you know, it is tragic to see those local community breakdowns where people used to be able to talk to the neighbor or the friend or the aunt or go to the church or whatever it was where they got their support. And now it just seems to be, I've got a problem, I go to see my GP. And we've got to get out of that cycle, because, you know, I am not the expert on counselling or being in the support work, you know, that support network. And so that's the NHS plan, is to try and reduce that and to use people's skills better. You know, like what you're doing here, Emma. This is absolutely fantastic. You know, you don't need, all the people who are listening, I'm hoping, are getting some information out of this, but this networking that you're doing is invaluable, because it empowers women, it supports women, it's signposts, it makes women realize that actually they're not alone. And that's, you know, yes, absolutely, I send to counselling for helping people to, particularly if they're very frustrated with the fact they've had surgery and still not getting anywhere. You know, there are other ways, but certainly what you're doing here is fantastic.
Yeah. So next question is why is it that GPs do not mention pelvic pain physio? This person found out through an endo group.
Yeah, I guess they, you know, we don't always have a pelvic pain physio. We don't. We're changing the way we deal with chronic pain. So I think people will start to be using them more. You know, we're all getting better access to physios as well. We're starting to think differently about the management of chronic pain, and much more use of the multidisciplinary team, the support net, you know, the psychologists, the pain management support team, maybe even the doctor in that pain team, but the physio and the OT, you know, because beforehand we'd have just gone up and up and up the pain ladder, and then run into problems with getting people off high doses of morphine when we sort of eventually got to the end of wherever we were and realized we were causing more problems. So there's being a real rethink about pain, looking at other ways of managing chronic pain. And hopefully that will be with more use of pain physio, but not every area's got them.
Okay, so is having endometrioma an indicator that there might be endometriosis somewhere?
An endometrioma means you've got endometriosis. It might be the only patch, but you don't have endometrioma without having endometriosis now.
Do you recommend anything to help prevent inflammation?
So by stopping the bleeding. So if you came to me and talked to me about, that young woman, we had the question, the young woman who was 3 months, maybe not that bleeding one, but if I had a 16-year-old come into the clinic and told me that she was having painful periods, or on the phone actually told me she was having painful periods, and I thought it was endometriosis, I would talk about, do we use painkillers, do we use hormones? I would try and encourage her to use hormones to start with, to get some sort of response and see where she's going with that, while she can go off and look at Endometriosis UK or find other helpful online resources. But it's about stopping the bleeding on the whole, in my easy way of looking at endometriosis, that will reduce the majority of the problem.
How common is being diagnosed with endo and PCOS, and does this affect fertility even more?
Oh, so the combination. So polycystic ovary syndrome is another chronic disease. It's a pre-diabetes actually. So it's another, again, it should sit as a chronic disease, but it doesn't. The main issue with polycystic ovary syndrome is the link with insulin resistance, and in the majority, not all women, but in the majority, about it linking with weight gain. And basically, the more weight you put on, the less frequent your periods will become, because you become more insulin resistant, behave more like a diabetic, and that reduces the amount of periods. So most polycystic ovary women will have infrequent periods, and they will be short periods. So on the whole, the majority of women who have big problems from their polycystic ovary syndrome will have less endometriosis problems. But the big ambition with polycystic ovary syndrome is usually about weight reduction, because we know that diabetes gets better on not type 1 diabetes, but the majority of diabetes that we see in the UK is linked in with weight gain. So by reducing weight gain, you will improve your insulin resistance, you will improve your diabetes, you will improve your polycystic ovary syndrome, but then you might get more frequent periods, and therefore your endometriosis might be more of a problem.
Can your diet affect the intensity of pain or the development of endometriosis?
I don't believe it can cause the development of endometriosis, although no one really knows why endometriosis develops, or at least I've not seen a paper that said that. And so therefore diet won't affect endometriosis. The only other thing I've ever read about weight and endometriosis is that I read years ago something about women who are thinner having more pain from endometriosis, but I don't know how true that is. And I don't think there's anything you can do in your diet that would make it easier, or not. Healthy diet always.
So this is my last question. So someone would like to know if hormones impact their mental health. Is there anything else that you can suggest in other than hormonal contraceptives?
Okay, so there are different types of hormonal contraception, and some will affect some women more than others. The Mirena, which is the hormone coil, has a very low dose of hormones. So on the whole, that, because it's put inside the womb, its main effect is locally. So if you did a blood test level, the level would be very low. If you take a tablet, then that has to go right through your system, so you get a higher dose. So some people respond to, and there are different preparations. So in the hormone coil, there's just one type of hormone, but in the tablets, there are different preparations, different combinations, and some will affect some women more than others. So just having had one try with hormones, don't think that that's going to be the same with all of them, because it's not. It's sometimes worth fiddling with the preparations to see if you can get something better.
Okay. I spoke too soon. I've got a few more, but we have a bit more time. So is endometriosis an autoimmune disease?
As far as I know, no. But as I said, I this is clever academic stuff. I'm the person who sits in the GP surgery doing most of the care. So I don't know. I really don't know the answer, I'm afraid. It'd be good if it was, because then you could start to think about the DMARDs, the disease modifying agents that we use for the likes of rheumatoid arthritis. But I've never seen anyone use that sort of thing.
Okay. Are there any signs to look out for endometriosis spreading to the bowel, bladder, and so on?
Are there signs to look out for? So that's why a menstrual diary is a useful thing to do, because some people will find that they get, when they're thinking about it and they're thinking about their symptoms, they will find that they will get pain when passing urine around the time of the bleeding, and that might make you think, oh, they might have patch inside their bladder. If you use tampons, you can put a tampon inside the vagina, and then you could see if there was any bleeding when you go to the toilet, when you wipe yourself, and that will give an idea that that's coming from your urine. Some women will get that pain on defecation, so when they go into the toilet, if they have their bowels open, they will get pain around the time of the period, and they might not realize it's in the cyclical pattern until keeping a diary. So I do believe that keeping a diary is good, because you will then see mood changes, pain changes, any other symptoms. Some women find that they have more pain during sex at certain times of the month as well, and that's one that's really underreported for endometriosis.
Are there any risks of multiple hormone treatments at once, for example, IUD and combined pill?
So taking the intrauterine, so the IUD is a copper preparation. So I'm presuming they're meaning the hormone coil and taking the pill. The answer is no, because the hormone coil is a very low dose of a hormone that's called progesterone, which is progestogen, which is we've got lots of progesterone in our systems. So it's a very low dose. The combined oral contraceptive is a mixture of estrogen and more progesterone, but the Mirena dose is very little, so you're not causing too much. It's the estrogen that is more of the risk, and some women can't take a combined pill because they might have migraine, or they might have a high blood pressure, or they might be overweight, or they might be aged over 35 and smoking. So there are some reasons you can't take the combination, but it's not the progesterone that's the problem. So using the Mirena and combined hormonal contraception, the pill is great. A good idea.
Okay. And the next question is chronic cysts connected to endometriosis?
Chronic cysts.
How?
Sorry, Emma, I missed the question.
Oh, sorry. So are chronic cysts connected to endometriosis? So it's like someone that's waiting for the laparoscopy, but they just want to know how it's connected.
Chronic cysts.
Mm-hmm.
So chronic cysts. So some women will have ovarian cysts, so they'll just have clear ovarian cysts, and they will have persistent cysts. And say you've just had a Mirena put in, if you scanned a woman, she would have a cyst, and you scanned her 3 months later, she probably still got a cyst, but that's because of the hormone. Some women just get persistent cysts, and they're just small cysts, and they're nothing to do with anything. They're just what that woman got. But an endometrioma is different because of, as I explained, about the picture that they'd see on the scan. So it's a bit confusing, really. I'm not quite sure what those chronic cysts are. If they're just chronic, normal ovarian cysts, then they're just there, and they're probably nothing to do with the endometriosis. It's just that she's been scanned looking for endometriosis and noticed that she's got some small cysts, which are common.
So someone's endometriosis came after open surgery to treat ovarian cancer. Is there a link between open surgery and developing endometriosis?
Open surgery and developing it. This again, it's a specialist question. Not that I know of, but I make up an answer, I'm afraid.
Okay. Well, thank you so much, and I've come to the end of the questions in the Q&A. Oh, just one more. Okay. So this will be the last question. So, do you recommend fertility MOTs? So this might be out of your area too.
Do I recommend fertility MOTs? Yeah. I absolutely.
Or any way. Sorry?
I absolutely do not recommend fertility MOTs. I think it just puts a lot of stress, and usually it's the woman who's been sent, and it's, as we know that sometimes it's the woman who's the clear culprit or whatever, for the reason is when the woman's problem, and sometimes we know it's the man's problem, and sometimes it's the combination of two people together, and lots of time there's no obvious reason, and then people start to put blame on, and the stress builds up, and actually anxiety is one of the biggest causes of reduced fertility. So no, I absolutely do not encourage women to go for fertility MOTs. I think it is completely wrong.
Okay. Well, thank you so much, Anne. Thank you so much for your time and answering all of these questions. We really appreciate it. And thank you for everyone who joined us tonight. This webinar will be on the website very soon, and so look out for our social media posts. We'll share it there too. But thank you.
Great. Well, thank you very much.